morning, everybody. My name is Daniela Lustig, and I'm part of our Global Scientific Affairs team here at Abbott Molecular. Thank you for joining us for our session for staying ahead of the changing HPV landscape, a 360-degree review. This morning, we'll cover a clinical and an operational viewpoint on HPV testing. We have two great speakers this morning, and so we'll take questions at the end of both presentations. Our first speaker, Dr. Mark Stoller, is a professor emeritus of pathology and clinical gynecology at University of Virginia Health System. He's a past president of American Society of Clinical Pathology and is still active in multiple professional organizations. Dr. Stoller is an author or co-author of over 340 peer-reviewed publications and multiple book chapters. His research has focused on relationship between HPV and cervical carcinogenesis and application of this knowledge to improving diagnosis and prognosis. He's currently actively supporting ongoing prophylactic, therapeutic trials, and clinical diagnostic trials for HPV-related disease as an expert pathologist and consultant. Welcome, Dr. Stoller. Our second speaker is Dr. Anami Patel, who received his clinical molecular pathology training at St. Jude Children's Hospital in Memphis. In 2002, he started the Molecular Diagnostics Clinical Service at the Methodist Hospital in Memphis, Tennessee, where he served as the technical director for 14 years. He has been a principal investigator for more than 20 diagnostic clinical trials involving molecular diagnostic assays and a co-principal investigator in a number of CDC-funded research projects. Welcome, Dr. Patel. Our main objectives this morning will be to review HPV screening in the U.S., current status and opportunities, as well as share with you some data on our high-risk HPV assay and how extended genotyping from this assay can be used to triage HPV-positive patients. So those two objectives will be covered by Dr. Stoller, and then we're going to transition into a workflow evaluation of our fully automated solution for HPV testing, and that's our Alinity MP pre-analytical solution, along as well with our Alinity M platform. And with that, I'm going to transition over to Dr. Stoller. Dr. Stoller?
Good morning. I guess the mute is off. Thank you, Dr. Lustig, and thanks to Abbott and to AMP for allowing me to participate in this symposium. You know, look back in my records, it's more than 20 years since I've been talking to AMP, which I helped to, was one of the founding members of AMP, been talking about HPV diagnostics in the context of cervical cancer screening and the dynamic between cytology, the original screening test, and molecular HPV testing. So let's talk about the current status of HPV testing in the U.S. We know that we've been doing cervical cancer screening in the U.S. for over 60 years. And if you go back 60 years, which is the late 40s and 50s or so, the U.S. was no different than any other country on the planet with no screening, with very high, not 14 per 100,000, but more like 50, 60, 70, even 100 per 100,000 incidence of cervical cancer. Everybody knew somebody who had cervical cancer. In the last 30 to 40 years, we've had a significant decline in the rates of cervical cancer, but as you can see here, due to screening, and this is primarily cytology screening using the pap smear, we can see that despite a lot of advances in cytology, the use of liquid-based cytology, the application of automation, that we've hit a plateau in the rates of decline in cervical cancer screening. We still see in the U.S., just around 15,000 cases a year, and 14 to 15,000 cases and 4,000 to 5,000 deaths, and that's kind of stable. And why is that? Why is that? Well, one of the reasons is that most of the cancer occurs in people who haven't been screened, and despite, public health campaigns from CDC and the American Cancer Society, et cetera, that have been repetitive for years and years. We know that in any given year, half of U.S. women haven't been screened in the last 15 or 20 years. And it's not getting better, it's probably getting worse. And COVID, of course, made it much worse. And there's blips in all kinds of screen cancers in the last 3 years due to lack of screening because people weren't going into the doctor for anything during the pandemic. So getting more people into screening is one important strategy. And the other key strategy is, especially since we've seen the plateau, what you're seeing is really, and believe me, I'm a cytopathologist, so I don't say any of these things lightly. You're seeing the limit of morphologic screening using cytologic diagnosis. There are lots and lots of clinical trials in this pooled paper that was published in The Lancet almost 10 years ago, where they pooled the data from 4 very large randomized clinical trials and looked at the rates of cervical cancer detection by cytology in women 20 to 64. So almost 175,000 patients. And what you see is this gap between the amount of cancer detected by HPV and the amount of cancer detected by cytology. And it doesn't matter if you've never been screened or unscreened, or whether you already had a negative initial screening test, this gap persists. And what it shows unequivocally is that HPV screening is, over 8 years, 60 to 70% safer because it finds more cancer, finds more precancer, prevents the development of cancer compared to cytology alone. And it's these kind of data, together with the large clinical trials, that have led experts around the world to say HPV screening outperforms cytology. So the message to the American Association for Molecular Pathology is, you won. Okay? The molecular testing is the way forward, and we see that now in the guidelines that are coming forth. And the guidelines have been revised. There were guidelines in 2000, 2002. 10 years later, they revised the guidelines again, and they're doing it again. And the interval is not going to be 10 years this year time. It's going to be 5 years. And USPSTF, which is a little older and more conservative guideline, still talks about cytology alone for screening, but the American Cancer Society in 2020 said that HPV testing alone, meaning HPV primary screening, which is not just the HPV test, but the HPV test coupled with a triage test, as we'll talk about, is preferred. Co-testing is also acceptable, and cytology alone does not perform as well. In fact, you have to do it more frequently to get somewhat equivalent performance. The other thing you see in the ACS guidelines is a simplification. So, for instance, when I started doing cytology, we used to screen women at the onset of sex. So you had teenagers being screened. Then they cut out the teenagers and started screening at 21. Now, most recommendations around the world and from the American Cancer Society is don't start screening until age 25. So simplification of guidelines, unification of things so that it's simpler for patients to remember, it's simpler for clinicians to remember how to do it, is part of this paradigm of improving cervical cancer screening by a combination of altering test intervals and doing molecular testing first. The idea being that if you get the patient in to test them, you should test them with the most sensitive test possible. Now, if the biology and the clinical science says that one testing methodology is better than another, then, and only then, in my opinion, do we ask the question, well, can we save some money? Is it more cost effective? And it turns out, as you might expect, primary HPV testing is significantly more cost effective, at least a third, if not to twice as effective compared to co-testing, because you basically eliminate cytology from the paradigm off the bat, because on average 10 to 15% of patients are positive and 85% are negative with these sensitive clinically validated tests that we're talking about, you eliminate at least 85% of the cervical cytology from the testing paradigm, and that has enormous cost savings, not to mention the fact that it's increasingly difficult to find cytotechnologists to screen pap smear slides. So you can see from this table the relative estimated costs and the fact that primary HPV actually detects more than primary cytology. And slightly fewer tests than co-testing, although when you delve into the modeling that supports these kinds of analysis, really primary HPV testing and co-testing are statistically identical in terms of their sensitivity and specificity. So the implications of primary HPV testing is mostly for the negatives. You get better reassurance of patients with a negative test compared to a negative cytology result by itself. So it's higher reassurance, which leads to longer intervals because you have better negative predictive value with HPV testing, primary HPV screening compared to cytology alone. And again, about the same negative predictive value with co-testing. So with that sort of background of why we're moving in all guidelines, and in several countries around the world they've already implemented this, some for almost 5 years. For instance, in Belgium, Netherlands, Scandinavia, they've been doing primary HPV testing now for about 5 years and are now reporting their long-term follow-up results. Let's look at the salinity assay, which, hot off the press, was approved by the FDA 2 weeks ago? 2 weeks ago. 2 weeks ago today. So this is hot off the press data. Now, this is a table of the 5 most common FDA-approved HPV tests. Not all of these are approved for primary screening. There are 2 other, what I would consider at this time, legacy tests, the hybrid capture test and the Cervista test that I don't know if a lot of labs are still doing this when they can have the kind of automation that's available with these tests. Actually, in the United States, the hologic aptamer mRNA test is the most common HPV diagnostic. But you can see the hologic test is not approved for primary screening, although it is used for primary screening in Europe. It doesn't give you 16 and 18 as discrete results. And in addition, you have to go back to the vial and do a second test. Nor does it do extended genotyping, and it's really only approved for use in the ThinPrep file, not the SurePath file. The other 3 tests, this sort of in the order in which they were approved, are the Roche test, the BD test, and now the Abbott test. I apologize for the 2 L's in alinity there. All of these tests give you 16, 18 genotyping results because in all of the algorithms that use HPV primary screening, it's been shown really clearly that HPV, as I'll show you in the risk figures, HPV 16 in particular, if you're HPV 16 positive, you have to go to colposcopy because you have at least a 10% chance, even with a normal pap smear, at least a 10% chance of having CIN3, which is a quite remarkable result. We used to tell people you have normal pap smear, you have no risk. Well, now you have at least a 10% chance of CIN3, and if you have an abnormal pap smear, it doubles. And if you have a high-grade pap smear, it triples. So it's important to know genotyping. And what we've learned in the last 10 years is that those other 12 types, all these tests have 14 high-risk types in their target analyses. The other 12 types give you an average risk, but what we found out by careful epidemiologic studies, for instance, in New Mexico, Dr. Young knows this, and many other studies in Europe, and then some of these clinical trials like the OnClarity trial, is that the individual types have differential risks. And the concept and the guidelines that we'll talk about in the end of my 20 or 30 minutes here really are all talking about what you do to patients is guided not by the result, but by the risk implied of the result. The risk being the risk for cancer and high-grade precancer, because we prevent cervical cancer by finding the precancers, treating them, and eradicating them to prevent the development of cancer. And the OnClarity test and the Alinity test give you genotypic information beyond 1618. The Roche test has a different approach. You've probably heard of it since it's been FDA approved for over a year. They use a dual stain cytology as a reflex test. They look at a marker for HPV oncogenesis, P16, and a marker of cell proliferation conjointly on a slide by immunocytology, and use that for triage as opposed to extended genotyping. And I'll show you some of those data. So the Alinity assay is designed like this. It's a PCR test that's broken up into 5 colors plus a cytology control. Gives you HPV-16, which accounts for roughly 60% of cancer and high-grade precancers. HPV-18, which, while only 10% prevalent in cancer, is felt to be important because a disproportionate number of adenocarcinomas of the cervix. You all should recall that it's not just squamous cancer, but adenocarcinoma and even small cell carcinomas that are associated with high-risk HPV transformation. And the adenocarcinomas are about half 18, half 16, as opposed to the squamous carcinomas, which are about 60 to 70% 16 and only about 20% 18. HPV-45, again, disproportionate in adenocarcinomas, although here you'll see an interaction between the prevalence of the virus, much lower prevalence than 18, and the risk of cancer transformation. And then this medium risk group of 33, 58, 31, and 52, you take these 7 types, 16, 18, 45, and what they call group A in this analysis, and those are the types encompassed by the nonavalent vaccine, the Gardasil nonavalent vaccine. So part of the thinking in the design of this assay, which was designed, quite frankly, several years ago, given the amount of time it takes to bring one of these assays to market with a full-scale FDA clinical trial, is that you could use these groupings to monitor the impact of HPV vaccination in the population. It's also true that these 7 types account for about 90%, a little more than 90% of all cervical cancers in all populations worldwide. And then you have a group that makes up the last 10% of cancers, but are still clinically significant, and hence they're included in this assay. And as those of you who are familiar with the virology of HPV, I mean, these 14 types are a subset of the 40-some mucosal types and the 200 total HPV types. And which types you include and which types you don't include in these assays is really a function of the trade-off in what I call clinical performance or clinical validation, because we're not testing for HPV. It's not like HIV testing where you want yes, no, they have HIV. You're testing for the risk of CIN3 or cancer. You're using the amount of HPV present as a risk marker for detectable precancer and cancer-related disease. And so a negative 16 on one of these assays doesn't mean you don't have HPV-16. It means you have HPV-16 at a cutoff level that predicts that you don't have CIN3 with a high level of confidence. So this was a large study, statistically powered, to have enough CIN3 and abnormal results to make a statistically appropriate prediction on CIN3 plus prevalence. About 15,000 women, most in a screening population, enriched in an abnormal colposcopy referral population, very similar to the other studies, although the size of the studies has decreased as FDA, the negotiation between companies and FDA, as the FDA has become more and more familiar with the parameters and performance in the U.S. population. And here you can see, you know, one of the most critical initial results, and you guys are some of the first to see the public results of this recently approved test. The FDA comparator is the COBOS test, so there's no major secret here. You can see the same level of sensitivity for greater than equal to CIN3 in both populations, about 94 to 95% sensitive for histologically adjudicated CIN3 plus endpoints. And then if we break out some of the different groups, this is using the comparator which groups the 12 other, you can see the differential predictive sensitivity. And in this clinical trial of 15,000 patients from almost 100 different clinical sites around the U.S., the cross-sectional, remember I said normal pap smear, this is all comers, not just normal paps, but normal paps and abnormal paps, all comers in this study. The cross-sectional risk for CIN3 for HPV-16 was about 20%. So 16s are going to colposcopy. 18s also are going to colposcopy because the accepted current clinical threshold for referral is if your immediate risk is greater than 4%. Why 4%, not 5%? This is the biostatisticians, again, trading off risk versus benefit, number of colposcopies versus sensitivity for CIN3. And then you see the 12 others are right around the cutoff of 4% risk. If we break it out further by the alinity risk groups, you can see some groups in some populations dip below that 4% referral. And I'll show you what these cutoffs mean in the current management algorithm. But the point here is that there's information in those 12 others, and you can get this information in a test like the Alinity M or the OnClarity test. You can get that without doing any more work, right? It's not another assay. It's not another go back to the vial. It's just these are the data that come out. And so genotypic information is provided in your screening test result. And the question is educating our clinicians, educating the population about the utility of using these screening tests. And I will admit that I've changed my tune over the last 10 years. I used to think it was too complex for anybody to handle, to remember these differential risks. Of course, today, our residents and fellows and the young clinicians don't remember anything. They, no offense, but they remember to use the app, which the ASCP has put out. So you put the data in the app, the age of the patient, their prior screening results, their cytology results, their HPV test results. Soon their genotypes, currently 16-18, but soon genotypes beyond 16-18. And that app gives you the risk, and the risk predicts the management. So you can graph these results on an ROC curve, and you see, HPV-16 gets you, 40 or 50% of the way. This is for CIN3, right? You add 18, you get a little higher up. You add 16, 18, 45 in group A, and you get right at you can envision an inflection point where you're trading off sensitivity and specificity. HPV group B doesn't add that much. It adds some sensitivity, but it really blows up the specificity of the test. Here's similar data in the lower dashed line is the same graph at a slightly different scale, and the yellow line is when you add in abnormal cytology to the different groups, because abnormal cytology does add data. The question is whether you need abnormal cytology to do this kind of risk stratification. And you can see the shapes of the curve, and this kind of information is very similar to another analysis we did. The one on the right was published in 2020, which was an analysis from the Roche Athena trial using individual HPV genotypes versus dual stain versus co-testing versus cytology alone. And in that analysis, you could see that the sweet spot was this triangle, which is right at the inflection point, which is HPV 16-18 genotyping plus dual stain cytology, gets you the best trade-off between sensitivity and specificity in terms of triage. So these data, together with a very large other package of data seemed to convince the FDA that the Alinity M high-risk HPV assay is clinically valid and ready for use in terms of both HPV primary screening as well as co-testing, and that the genotypic information is really going to become more and more part of the conversation. Since 2019, there's been what's called the Enduring Guidelines Group, which is a group of clinicians and cytologists and molecular biologists organized with the NCI as well as 19 other stakeholder organizations, including most of the cytology organizations, et cetera. They developed an improved app, which is, I think it's $10 if you're not an ASCCP member and free if you are an ASCCP member. It's available, and the point of this is it's called the Enduring Guidelines because unlike prior guidelines, it's supposed to be a living document and a living app that will take ongoing clinical trial data, ongoing literature data, and if indicated, improve the app by incorporating additional types of testing into the management algorithm. So for instance, dual stain cytology has been reviewed. It is out for public comment. Extended genotyping is being reviewed. All these reviews have been delayed 3 years. All this was supposed to be done, but COVID, like so many, put a dent in those plans like so many other things. So I think what you're going to see in the next probably year or two, you're going to definitely see a revised American Cancer Society guideline. My colleagues from the American Cancer Society are giving a similar webinar, not on the Alinity, but on this, the project of revising the ACS guidelines at the cytology meeting, which is happening right now, overlapping with AMP. So if you're a cytopathologist, you had to make a choice as to which meeting to go to. USPSTF is also revising their guideline, and I would predict, although I don't know, I'm not part of it, that you're going to see a bigger emphasis on HPV rather than cytology. And ACOG usually follows and synthesizes after ACS and USPSTF. We want to emphasize that primary HPV screening's power and safety comes from the sensitivity of HPV testing, and that the main impact of that is better reassurance for the HPV negatives. For the HPV positives, we would predict that triage of the HPV positives will include some combination of genotyping and perhaps other molecular testing, depending upon the age and other risk factors in the patient's clinical history. And this is the way the algorithms are currently working. We seem to have consensus here in the U.S. that if the immediate risk of CIN3 or cancer is 4%, you're going to potentially go to colposcopy. And if you do go to colposcopy, there are different risk thresholds for what they do to you at colposcopy. For some patients, so let's say you have a 45-year-old patient who is done with childbearing, has an inadequate colposcopy, meaning you can't see the squamocolumnar junction, meaning sampling is really problematic. And there are lots and lots of lesions up in that canal, potentially, that you can't see, and therefore you can't biopsy them reliably. And we won't talk about ECCs and how bad they are for those of you who know anatomical pathology. But somebody like that who's HPV-16 positive, in my colpo conference and colpo clinic, some of those patients, even with negative biopsies, are going right to cone. Or they may go right to cone anyhow because you don't want to miss potential disease, and there's a huge false negative rate even with multiple biopsies. An intermediate risk category, somewhere between 25 and 59%. Again, HPV-16 with ascus fits into this. So again, depending upon the age, you might not want to do a cone right away on a 25-year-old who wants to have a baby this year. But on a 50-year-old with ascus and HPV-16 or HPV-31 or 33, some people will consider treatment. The ASCCP says this is acceptable. Lower than 25% risk, do colposcopy, but we could have a whole separate talk about the sensitivity and performance of colposcopy. If the risk is less than 4%, well, then we look at long-term risks, and these data are harder to come by. None of the FDA registration trials, excuse me, ran 5-year trials because of the cost. But there are 5-year data coming out of Europe and Canada and Australia, and in those situations, we're getting good ideas of what the risk stratum look like. And, you know, depending upon where you are, less than 0.5%, more than 0.5%, you can either go for 5 years, 3 years, or 1 year returns for a repeat test. The point being that screening is now guided by CIN3+ risk, patient's age, their desire for childbearing, et cetera, also play into the decision making, and triage is only needed for the HPV positives, even though I should emphasize no test is perfect. You're never going to catch all the cervical cancers, but I'm not sure we ever will or can. And also bear in mind that the performance of screening is also driven mostly not only by risk, but it's also driven by prevalence. And another reason why we're moving to HPV testing is that you need improved sensitivity at low prevalence. The prevalence of CIN3+ in the population is less than 1%, right? So if you know how to do Bayesian statistics, at a 1% prevalence, even a 90% sensitive test is starting to fail in performance. So it's 50 to 70% sensitive tests like cytology is mostly false positives, which is what ASCS is. So I hope I've convinced you in this relatively brief presentation that primary HPV testing has the potential to reduce the prevalence of invasive cancer better than cytology alone, probably equivalent, we could have a discussion about this, to co-testing, that guidelines and the use of these tests is going to evolve. I think it's going to evolve rapidly, even though we've been talking about this for more than 20 years. I think finally the data and the weight of consensus favors molecular diagnostics as the first-line test, although, as we were talking about briefly, as long as they, in my opinion, as long as they reimburse for other methods, there's no teeth in the guidelines like there is in Europe. I mean, the Netherlands has a unified single healthcare structure. Sweden has a unified single healthcare structure. They say you're going to do HPV testing. That's all you're going to do, right? There's no other choice. Here, clinicians still get to do a lot of what they want despite guidelines, and the pros and cons of that we can talk about. And I think extended genotyping, like is available in the Alinity test, the OnClarity test, is going to be important data in the potential decision-making equation, because it helps you split out the patients in a very cost-effective and laboratory workflow effective manner. And with that, I guess we're not going to take questions. We're going to we can take questions.
We'll take questions at the
end of the session. So I turn this over to Dr. Patel, who's going to talk to you about the real world.
Good morning, everybody. Thank you, Dr. Stoller. This is very nice review, and definitely I would like to have like a continuing education credit out of this. So what I'm going to do, the topic is real world workflow evaluation. So we heard about HPV testing and co-testing, what should be moving forward. I think I have been convinced what Dr. Stoller we heard just now. So saying that, let's get out our disclosure first. So the company I work for, PathAI Diagnostics, we are the third largest independent commercial lab, anatomic pathology. So we are based in Memphis, Tennessee, very strategically located FedEx logistics-wise in Memphis, Tennessee. That's where FedEx World Headquarters is. And we are about 113 square feet, very large laboratory. We process almost 2,500, 2,400 samples per day, and the excellence for the digital pathology, along with molecular diagnostic testing. So the objective for my talk today is we wanted to look into our operational efficiency. And that's the buzzword nowadays, and we'll get into that, why operation is very important, and what are the solutions out there available to do that. So we have been tasked with that with our administrator, how we can bring the efficiency in our operation, what we do every day. So the objectives were, can we automate what we do currently with the other technology out there, maybe available in the market, including both pre-analytical and analytical. During COVID, we all learned it's hard to keep the staff or recruit new staff, and then how do we utilize the current staffing, full-time employee utilization. Then also at the same time, reagents and consumables, not only the supply chain, but also the pricing, not necessarily for the reagent pricing, but the wastage, like batching, even if it is automation, when we batch, how can we save the wastage? So that's what we're going to talk about. And the turnaround time is always very, very important. Everybody is asking like results yesterday, even before the test is being collected and ordered. And then how do we consolidate the women's health testing? At PathAI Diagnostics, we have very comprehensive testing, women's health testing, so we're going to talk about that. So considering these objectives, just to give you an idea for women's health testing, this is the test volume. Per day you can look at chlamydia, gonorrhea, trich, MGen, bacterial vaginosis, CV, and HPV. So if you look at the HPV testing, very decent volume, somewhere average around 150 tests a day we do. And the expectation is, like I mentioned, we want to turn around the result within 24 hours of when we receive the specimens as a reference lab. So considering this fact, we looked into workflow evaluation with Abbott. So this workflow evaluation included both pre-analytical as well as analytical. So for pre-analytical and analytical, this is the workflow we learned from Abbott, that this is the solution, probable solution we have. So we can have a thin prep vial or a SurePath. Currently, we don't have so many SurePath vials. The majority of the testing volume on HPV is thin prep, but SurePath is also can be processed through this workflow. So LNET-M, which is a pre-analytical instrument, not FDA approved yet, and then we aliquot that, which we're going to talk about in a minute, and then we take it to the LNET-M instrument, which is their PCR instrument, and then it goes to LNEQ AMS platform. So it will organize the data, analyze the data, and then directly send it to our LIS system. And then through LIS system, we can provide result back to physicians. So this is a fully automated, including pre-analytical and analytical process. So looking at LNET-MP pre-analytical, what it can do for us in the lab. So it is designed to include several different features, such as the original vial. We just load the original vial, thin prep vial, on the LNET-MP instrument. It will decap the vial, and then it will vortex. It will put the label on the secondary tube, and then goes back and recap the original vial. So the aliquoting of the samples in the liquid cytology vial to the secondary tube, that secondary tube goes directly onto the LNETM instrument. So that is kind of like a automation for pre-analytical. And obviously, I'm sure a lot of people know here about LNETM system, but some of the features are they are random access. So random access means if I have like all the tests, women's health testing, which we saw, we can put on LNETM. So CTNG, if I have one rack of CTNG samples, another rack for HPV, so I can randomly access those, put on the instrument rather than batching of 96 samples, and then continuous access. So I can come load the first rack of HPV. I can come within next few minutes when I'm ready with my CTNG. So that way it is a continuous access. And what it does for my first rack, which has 12 samples, it takes about 115 minutes to get the results. So we don't have to wait for entire batch to finish to have the access for the results. And in one shift of 8 hours, the throughput on LNETM is about 300 different tests. And the capacity for LNETM is about 20 tests we can load and run simultaneously. And that would include both FDA approved and not FDA lab developed tests. And another important feature is stat prioritization. So when we have a priority, somebody is calling us, hey, we have a patient or a staff member for COVID test or respiratory test, 4-plex they have as FDA. So we can load that sample on a different rack, and we can do that as a stat test. So now knowing the features of LNET, both pre-analytical and analytical, this is more of current pre-analytical process, what we have in our lab right now. So as soon as we get batch of thin prep vials, what we do, which is a manual process, I'll walk you through. So we print the label on the aliquot tube manually, and we put that. We manually transfer from original vial to the secondary vial, and then it goes to the instrument, our current instrument, which is Cobas 6800. So that takes about 30 seconds per sample. And if you think about 150 total samples a day, how much time it will take. So we have to have FTE to process that sample manually, opening up the vial of the primary tube, take the aliquot into the secondary, which has already barcode label, which our tech will put it on, and then we take it to the instrument, analytical instrument. So, and in between vortexing time. So if we counted this time, so it takes about 30 seconds per sample during pre-analytical, and then vortexing step will take another 12 seconds. So altogether 42 seconds. Just keep that number in mind. So when we looked into the automation, so what we felt like looking at the features of LNET MP, we felt like we can eliminate those steps of 42 seconds, which it takes per sample, 42 seconds. So we thought that, well, let's look at that and evaluate this pre-analytical process with our current workflow. And so total hands-on time for HPV aliquoting, we were able to eliminate. And then at the end, with our calculation, we were able to save, like forecasting, about 409 hours of labors per year. So that would be equivalent to 51 FTE days. So one of the objectives, as what I mentioned about FTE, is utilization, which brings to the operational efficiency. This was pretty attractive to us. So looking at more at the data, so for this evaluation, so we at the time when we generated this data, HPV was not FDA approved, and obviously Alinity MP is still not FDA. So on 2 different days, we process our routine samples along with our clinical workflow. So first day, about 102 samples we received and processed them clinically, as well as on this for the evaluation purpose. And on the second day, we went back, another 118 new samples we processed, they were received on second day. And the data I'm going to show you, which we followed very, very closely, how much time it took, hands-on time per day, to process first day 102 samples, second day 108 samples. And then what was the time it took to process the samples both days. So here is on the table the comparison semi-automated, which is our current clinical workflow, and automated with Alinity MP and Alinity M. So with semi-automated hands-on time per day range from, for 102 and 118 samples, range from 1 hour 13 minutes to 1 hour and 24 minutes for those samples, semi-automated, which is our current workflow. And then when we looked at running the same samples, same number of samples on Alinity MP and Alinity M, it took about 13.3 minutes to 14.45 minutes. So that is a significant reduction from hour and 13 minutes to 13.30 minutes. So this reduction was about 80%, which is significant. And then we also looked at turnaround time for the test of record analyzer. So if you look at on the table, day 1 for 102 samples, estimated processing time in the middle, I have put the data for the 12 samples, 24 samples, and 94 samples. We don't do 12 samples or 24 samples. We just go with the full batch. So we will wait until we have all full plate. So if we are getting 112 samples, what that means is we're going to go and run first 94 samples, and we'll wait for rest of the samples until next day. So we are not achieving that. For that reason, our expected 24 hours turnaround time. So for 94 samples, it took minimum of 4 hours and 30 minutes for processing time. And with our semi-automated, which is current. And when we looked at fully automated, it took about 5 hours and 30 minutes. And then average is about 7 hours. And it can go up to maximum 12 hours with those 94 plus rest of 108 samples. So at the bottom, number of samples, when we compared between semi-automated and this fully automated, it is about the same time period. As you can see, 5 hours and 36 minutes with semi-automated versus fully automated 5 hours and 42 minutes. So we are achieving the same time, but we are taking the time, we are gaining hours from our FTEs, right? That is the main objective we had. And then also, like with the Alinity M, the random access and continuous access, which gives us the flexibility of loading those samples, processing those 108 or 112 samples, 118 samples each day without wasting our consumables. This assay is designed and approved where we have to run controls, external control, positive and negative control once a day. So if I'm coming back in the afternoon after my morning batch, I don't have to run. I can go ahead and run without controls. So that way, these are some numbers that how we can maximize our operational efficiency. So pre-analytical and analytical, just a few takeaway from our initial study with this automated. We were able to see the 80% of the manual pre-analytical sample preparation. So that is significant reduction in our FTE time. And the time what this 80% time we gain back from our FT, what we could be doing. So this time, our tax can be spending for a lot of other activities, like documenting quality control, quality improvement, and then maybe training for or cross-training on other benches. So other thing is the random access, which I talked about, the controls. We don't have to keep running multiple times on a given day. And then it has also shown us that we can have increased capacity for additional testing. Thank you.